Hi, everyone, and welcome back. Welcome back to our online participants as well. So this last session today, before we wrap up, is really asking us to look at what's coming in the future. What is next? And we have some excellent experts who are with us, who are going to help us in sort of a reaction to what we've been talking about, and then also reflecting on their specific perspectives in the projects and work that they do, but really helping us look at what's next for this movement. As you know, we are 8 years old, and we want to be able to continue to make progress, accelerate progress, and recognize that we have to continue to really amplify the work, particularly in finding and implementing solutions to the issues around workforce well-being. And so, as you've also heard others say, this is a movement. This is not a project. This is not a perpetual exercise in study. It has to be action-oriented, hence Action Collaborative for clinician well-being as leading all of this. But we want to make sure that we also are taking advantage of learning from prior experiences, prior movements in healthcare, to make sure that we are able to accelerate our work by not repeating unintended mistakes and consequences of prior movements. So before I introduce our guest speakers, I just wanted to give you a few more comments on the Action Collaborative and the work that we've been doing that has gotten us to this point. And like several others that you've heard from today, I have had the pleasure of being part of the Action Collaborative since its inception. And so when we take a look back as to how we got to where we are now, like many other aspects of life in healthcare, there's a pre-COVID and a post-COVID. And so this group started prior to any inkling that we were going to have a worldwide pandemic. So when we started in 2017, we were realizing a lot of disillusionment, a lot of burnout being talked about. And what was interesting to me, being part of those very early discussions, is that we actually were not using the same vocabulary, even talking about burnout and the consequences. As nursing has demonstrated for a long time, we talked about moral distress. And actually, to many physician colleagues, that was a new concept, which surprised me because I thought it was kind of universal to healthcare caregivers. And so we had this constellation of issues that we were trying to come together around in an interprofessional way to really look at what did we need to do together. We also did recognize there was fear of reporting any kinds of issues, whether it was just burnout, I need a break, versus I have a really serious mental or emotional issue that's keeping me from being able to practice. So the early work of the collaborative was very much on building awareness. And we put out papers, we created a knowledge hub. Maybe some of you remember this, but maybe not everybody. It seems like truly a lifetime ago. And so really did, I think, an outstanding job of setting the stage, which we didn't know, again, was going to just explode a couple years later. We also were successful in asking NAM to do a consensus study. And that was actually, again, a major step, an initial turning point in the work. And hopefully you've, at some point, read the results of that study. And it just codified that we needed the conceptual framework that was refined during that study. We understood that we needed to address not only the organizational differences, but all of the other big systemic factors that were impacting the work life of clinicians. And so, top of the list for many years was electronic health records and the burden that they were perceived as imposing despite the positive characteristics and impact on patient care. We also knew that there were financial pressures. We also heard stories and personal testimonies of discrimination and intimidation and bullying to healthcare providers. We heard that specifically from underrepresented groups and women in medicine. I mean, that was pretty rampant. And then we also heard, again, more workflow issues, other regulatory issues like prior authorization and things that were just a burden. And so then while we were talking about all these things and producing all these great resources, COVID came along. And so that really forced us to immediately recognize that we were seeing a tremendous impact on our healthcare workers. And I don't need to tell you that story. But again, we realized it was more important to focus on issues that hadn't bubbled up in the initial phases, particularly the issues of stigma, particularly the issues of mental and physical fatigue, particularly the issues of moral stress, distress, and moral injury, and also then what appeared to be a significant exodus from all of the health professions, whether it was temporary or whether it was going to be permanent. And the other thing that emerged that's been part of the mantra of the work of this group has been, it is not the clinician's individual responsibility to heal themselves, to address these issues and precursors to actually developing burnout. It is an organizational, a system responsibility, and we've hopefully spoken that from the mountaintops over and over again, because we all know that the initial result of dealing with COVID was to say, go to a yoga class, go learn meditation, go find a way that you can, go take a walk in the woods, and we all know that that was not the solution. So again, I think you may have heard this in some of the comments, our collective energy came together around developing the national strategy and that roadmap for how we needed to bring different players together, how we needed to approach it on a systems care delivery level, a policy level, and a public information level. So all of these things are still a very active part of our agenda to work on the 7 strategic areas in that plan. The other thing that was stressed, and you heard this in some of the previous panels, was we focused on how do we help make the clinician, or the entire healthcare workforce, feel valued, because that was part of what was lost during the pandemic. I think it was Greg that said, caregivers were feeling like they were just a number. And again, that was not necessarily only post-COVID, but again, I think really was highlighted in terms of that feeling like there was no value or respect or protection for workers. So really coming together around recognizing that the movement needed to address all the things that we were learning pre-COVID, but then also very rapidly needing to address those in the post-COVID time. Because we know that, and we've seen, additional shocks are hitting the healthcare system every day. So even as we've emerged from some of the most stressful ones of the pandemic, we're now in yet another phase of stress and shock in terms of uncertainty, in terms of financial pressures, in terms of not knowing how policy changes are going to affect what comes next. And so it really, I think, again, puts the burden on us, an appropriate burden, to say, please accelerate our work, make sure that we are coming up with implementable, sustainable solutions that can be generalized across the healthcare industry. So as we think about where we're going, how do we sustain this movement and what's next, I know that this is probably top of mind for many of you too, because we all want a solution. We want to be successful. So I'm very pleased today to introduce the 2 speakers who will share with us, again, their perspectives and some very specific programmatic experience. To my immediate left is Polly Pittman. It says Patricia, but she goes by Polly. And she's going to provide a recap of the HRSA Workplace Change Collaborative and what it's done for the field and what's next for grantees. I want to tell you a little bit about Polly. She's a professor in the Department of Health Policy and Management of the Millikan Institute School of Public Health at the George Washington University and holds a secondary appointment in the School of Nursing. Again, she's with the Fitzhugh Mullen Institute for Health Workforce Equity, and she also directs the Health Workforce Policy Research Center. And she's been very involved for many years in focusing on workforce innovation in the context of systems change. Our second speaker, Terry Fairbanks. Again, everybody has a different first name. Well, yours is correct on your name tag. I think in the program you have we've got you down as Roland J., aka Terry Fairbanks. And Terry is Senior Vice President and Chief Quality and Safety Officer at MedStar Health and Professor of Emergency Medicine at Georgetown. He has done a lot of work centered on application of human factors and safety science in healthcare. He is a leading expert in patient safety, and he brings his background not only from healthcare, but also being a general aviation pilot. So he's been able to bring together that expertise, particularly in looking at human factors and how it affects the work that we do. Terry is going to share with us his work with IHI. He's head of the Certification Governance and Oversight Committee, and he's going to report out some things that have just come from the recent IHI meeting, and then also help us understand what are some of the intersection points, because as you know, IHI has been involved for quite a long time as well, looking at joy in work and well-being. So Polly, let me start with you.
Great, thanks. And thanks for hanging in there. I know this is the last session of the day and everybody's exhausted. It's a delight to be here. My role is largely to report on a 3-year project that was funded by HRSA. You all may recall, and we can, let's see, am I controlling slides? Yeah. There we go.
The big green one.
Yeah. Oop.
Yeah, the big green in the center. The big green one.
Okay. So, you all may recall that the Dr. Lorna Breen Healthcare Provider Protection Act of 2022 funded 3 large projects. Actually, the funding came through a prior legislative mechanism, which was the American Rescue Plan Act of 2021, but it was following on the ideas that had been being developed by Senator Tim Kaine and the Lorna Breen Heroes Foundation around 3 big projects. And one of them actually has 3 parts, and that's the one I'm going to be talking about. There was also one that went to the American Hospital Association around suicide of clinicians, and a third one that went to NIOSH around creating kind of an employer guide for improving employee health worker well-being. So what I was going to talk about today is just the part that we were involved in. We at the Mullen Institute at GW, in partnership with IHI, with AFT Healthcare, which is a labor union, and with Moral Injury in Healthcare, which was the Wendy Dean, Simon Tabbitt organization, partnered to be the Technical Assistance Center for 44 grantees. So this was a collaborative agreement. It's not HRSA. It's not a HRSA project. It's not a contract. So the disclaimer on the first slide speaks to that nothing that I say in any way represents the views of HRSA. So our role was essentially, there were two strands, just for sort of historical purposes. There was, first of all, it included both health workers and public safety workers, which was kind of an odd thing for those of us who've worked primarily on the healthcare workforce. We had to do a lot of sort of dashing to catch up around. Thankfully, the police force was not included, but firefighters and EMT and other kinds of public safety workers were included as well. And there's a whole literature on the problems that workforce faces. So we were addressing, and the grantees included those kinds of workers as well, although they were clearly in the minority, and we constantly had to remind ourselves to add on public safety workers. It was a bit awkward, to be honest. But there were two sort of strands of grants. There was the Public Safety Workforce Resiliency Training Program, which has this horrible acronym. It was 34 grants. And then there was the Health and Public Safety Workforce Resilience Then there was the Promoting Resilience and Mental Health of the Health Professional Workforce, which had 10 grants. And I don't think anybody actually could figure out what the difference was between the two. There were different divisions within HRSA that had different program officers. It was sort of unclear to us. We thought first it was sort of education and practice, but it was not really that clear. So we worked with them all together. And then we were the technical assistance arm. And the technical assistance arm was asked to do 2 things: to support the work of all of these grantees and to develop a national framework, which is, again, a little bit awkward since the NAM had just come out with their framework, and there was the Surgeon General framework was about to come out, and so here was yet another request from the federal government to create yet another framework. But that was nevertheless the mandate, and we did that. You can find that framework on our website, the WPChange.org, Workplace Change Collaborative website. And I think in relation to the framework that came out here, it was absolutely building on that. It had a little more emphasis because of our partners, Wendy Dean in particular, around moral injury and around some of the more structural and system level drivers, if you will, of distress and attrition of the healthcare workforce. This notion of betrayal by authorities, the notion in particular that healthcare workers are often unable to do the work that they trained to do, this idea of sort of structural impediment. So we put that as something that was both a driver of burnout, but also an independent concept that was related, so overlapping concepts. So that project has largely come to an end. There's some folks that have carryovers, but it ended in December of last year. We have done a series, there's a formal evaluation partner, NORC, that is external, which we didn't know at the beginning of the 3 years, and so we had actually programmed in our own work a fair amount of monitoring of what was happening. So what I wanted to quickly report on was just the results of the surveys and focus groups and interviews that we did, particularly in year 3, which are essentially the voice of the 44 grantees and what they thought was working and what some of the challenges were and lessons for others in the field. And I know as part of this collaborative, some of those grantees have been here and have actually been speakers as well. So there's some overlap. And I would say, actually, having listened to the prior 2 panels, that particularly the experience in San Diego, Habib, is very much in line with what our grantees were saying were sort of the lessons learned, and the language was very similar. And it really leads me to conclude that rather than having something sort of new to present right now, I think what I'm presenting is a real validation of where the field is or where the movement is. There seems to be a lot of consensus around some basic principles, and I don't think that we had those 3 years ago. So I think the journey of these grantees and the journey of this collaborative, both collaboratives, sort of has been very clearly going from point A to point B, and point B is very different from point A. So I think that it's just a validation, if you will, and that we're at this sort of plateau of taking stock of where we are. But very generally, the 44 grantees were working on things related to wellness and resilience, was what the RFP had actually called for, but also a lot of work around mental health, stress and trauma, changes to the work and learning environment, reduced workloads and improved workflows. Interviewees, there's a strong consensus that the concept and the word in particular of resilience and resiliency was sort of had to be dropped urgently, that it created all kinds of bad reactions from employees, and it was triggering. And so I think pretty much everybody moved away from that concept really quickly. And something that I think that was those grantees that focused on access to mental health services and substance abuse issues were perhaps the most successful, and just a quote from one of them, it's something I'm so insanely proud of, that workers are comfortable with saying that they're seeking help and it's helping them. So this was a clear, for a subset of grantees, really, really strong. So the little pie chart on the right is just, it was a drop down of options for your top 2 areas that you as a grantee identified as the drivers of burnout and moral injury that you were targeting in your interventions. And I would point out here that it's quite diverse, but I think what's sort of interesting to me is that while initially, i.e. when we were in point A in the history of this, the efficiency issues and excessive demands were really the focus, we now see that distrust and values conflict and lack of control occupy almost as big a part of the pie as the others do. And I thought that's where we are in point B, that those issues, which are, I would argue, more related to moral distress, moral injury, have really come to the forefront, in part because that's what the workers are saying is the problem that they're experiencing. So I think that's been a real evolution from the time that HRSA put out their first RFP around resilience. There was a lot of sort of consensus in general that the grants allowed them to build their capacity to address worker well-being, and that they had some signs of improvement. It was very varied in terms of how they measured the signs of improvement, but that there were signs of improvement. So some measured burnout, secondary trauma, turnover, intent to stay, engagement, trust, participation rates in the activities themselves, people accessing care, participation rates, those all over the board in terms of the outcomes. And that's one of, I think, the lessons that we heard from the grantees about what they'd like to see going forward. So I'm going to just reverse the order of this and talk about some of the challenges that they reported. I think the first one, there was a lot of reticence of employees and workers to participate in these projects. Initially, recruitment was not easy. There was, I think in part it was because of some of it was language, but also people were just really angry in the start. There were resource constraints and competing priorities, particularly coming out of COVID in 2022, that were major challenges. A lot of concern about, now that this money has gone away, how they're going to sustain these activities. And this, number 4, is sort of, I think, a huge takeaway and probably a way forward for your collaborative as well, which is that they really were demanding and had actually looked to us to do something that we were not authorized to do, which was to provide sort of practical, standardized tools to measure the grant impact. And so there was a real clamor for, what is everybody else doing? How are they measuring it? And which is the best way? And what should we do? But we were told by HRSA that we were not allowed to actually say what we thought about those things, that it had to be sort of a million flowers bloom kind of mouth say tongue thing. So that was really frustrating to the grantees. They didn't like that. And I think going forward, that's an area clearly where more work needs to be done. The major lessons, and again, these are the ones that I think that Habib and others have pointed out, that the importance of designing programs with workers as active partners, emphasizing trust, flexibility, and responsiveness to needs and context, even when it meant pivoting from their initial project proposal. Their realization as a team that the leaders were in bad shape as well, and they needed to include the leaders as part of the recovery process. That these one-off wellness activities and individual coping strategies, which, by the way, were the majority of the projects when we started, really were insufficient. And at best, they hoped that they were kind of trust-building steps towards something that was bigger and organizationally more comprehensive. And basically concluded that sustained improvements require attention to organizational culture, worker voice, workload, systemic drivers of stress, and that the greatest successes were tied to catalyzing cultural changes that placed workforce well-being at the core of business. So, yeah, I would say there's nothing new there, but just to say we're all in agreement. That's what seems to be the takeaway. So the worker-centered voice issue is clear: learner voices in program design, leadership development and accountability structures with shared measurement. And then the shared learning platform was something that I think was valued in their surveys. They really enjoyed having a way to communicate across grantees, and one of the things we did was a monthly call that was sort of based on the IHI model of a breakthrough collaborative, where they had teams that were participating, and there would be topics every month and folks could share, and that was something that was highly valued and they'd like to see going forward. So with that, I'll stop, and I think there are just some implications for the work going forward, but it is kind of a natural point, which I think to take stock and recalibrate the work, if you will, going forward. And I know, of course, Corey Feist and others are furiously educating our representatives on the Hill, trying to get the Lorna Breen Act reauthorized, and we shall see how that goes. Thank you.
Thank you, Polly. I think it's gratifying to also hear many of the outcomes that were discussed, and some of the key areas within the grantees actually reinforce a lot of what we heard already today from the other presenters. And so I think those points will be important for us to, as we think about summarizing this meeting, and as we think about the steering committee saying what is next, where do we go next, being able to learn from that group has been critical. Thanks. Okay, Terry.
Great, thank you, and thanks everyone for the invitation. Excuse me, I'm really happy to be here. As said in the introduction, I'm representing the Institute for Healthcare Improvement. I sit on one of their boards, the certification board. And as was mentioned, we just came from the big annual meeting. So what I've been asked to talk about really specifically is the intersection between quality and safety and wellness. And many people have talked about it today. Sue Sheridan brought it up very specifically as the partnership with caregivers and patients and families, which is so important. So I thought I'll talk about it from a few perspectives. My role in a health system is I lead quality, safety, infection prevention, and health equity. We do that with a really strong partnership with patients and family, and we think that's very important. And we do it, one of my closest partners in my role every day is our Chief Wellness Officer, Dan Marchalik. And we do this together because we really believe that high-quality care can't happen without people who have joy in the care they give. And I don't have to tell all of you, and I really deeply believe that people go into health professions because they want to help people. They're so driven to do that. And for so many, the system seems to fail them over time, and that's a lot of where we get our moral injury. So my comments will be representing a few perspectives. One is as a safety science, my academic background as a safety scientist. So I'm going to talk to you really specifically about how well-being of our workforce really impacts the safety of our patients. And having come from the IHI meeting, I had 3 days filled with, 4 days talking to my colleagues a lot. So I feel very refreshed on how the world is thinking right now about safety. And for those of you who don't know the IHI, it's I think the largest international convener of people who think every day about high quality care to our patients. So one thing that's important in this discussion is to think about what high quality care means. When you think about quality metrics, you think about what the patient says is they say, how does my care measure up against a known benchmark? And that's measurable. You think of the quality metrics that are out there, which we all really believe are probably the best things to measure to make sure we're doing the right thing for patients. And that's different from safety, which is the patient saying, don't harm me. And it's handled it's all part of quality, though. High quality care means good patient experience, safe care, measured against a benchmark well, and also equitable care, where the patient says, do you give me a fair opportunity to be healthy and to get high quality care? And that's what people in the IHI community are thinking about every day. I want to drill down on safety to relate it to workforce and to connect the dots to think about workforce wellness and well-being. If you think about safety, not just in healthcare, but in any complex high-risk system that depends on human performance to do well, you think about it and divide it into two pieces. One is, how do we proactively create and maintain a really safe system? And the second is, how do we respond when things don't go well? And those things interact so well. And I'm gonna talk about wellness in both capacities. But let's start with when things don't go well, because how we react when things don't go well and after an adverse event or an unknown, unexpected event, the reaction that we have deeply affects the wellness of our caregivers, deeply affects the wellness of our patients and families, and affects our ability to learn. And I think the modern way to look at this is that if you do it right, first of all, you don't wait to figure it out if there was an error, because the patients and their families are immediately concerned when there's an unexpected event. So you make sure that your teams are reporting any unexpected event, and then you take the time to learn and figure out whether there was a misadventure or something that should be an apology. You have to be transparent in this. So the value of that is you immediately create a transparent communication with the patient and their family so they know that you also are worried about what happened and you're going to look at it. And that creates this safety for the caregivers. They feel like it's okay, they're supported, and that's the second really important reason to get in there early, is to support the caregivers so that they feel like they can talk to the patient and their family, and they feel supported no matter what happened when they go home that day. And I'm glad we've talked about Lorna. I'll just say as an aside, I didn't think I'd be saying this, but Lorna and I went to medical school together, and we both were emergency physicians. She was a year ahead of me, and she was president of the emergency medicine interest group the year before me and handed off to me. She was a bright person who was happy and who was a great leader and who wanted to help young me be successful. So what a great example of somebody that we ruined, the health system ruined in terms of wellness, just as an aside. But how we handle events really affects the well-being of our people. It also allows us to learn right away. How does that relate to the earlier part? If we're really going to get to zero in safety and not have safety events, we can't wait till there's an event and then learn from it. Because any logicians in here know that you can never get to zero if that's how you learn. So you have to learn by being proactive in identifying the risks and hazards and mitigating them before it affects a patient. And that also has a huge well-being component, because you have to create an environment where the people taking care of patients every day who see the risks and hazards every single day are comfortable talking about it, comfortable raising it, they feel supported. The single most important impact you can have on that safety culture is how you respond to events. If you don't respond to them well, people will not trust you, and they will not report the near misses and the things that would otherwise go undetected. And the families are still seeing this stuff and worrying about it, so it's so important. So when you do that stuff well, when you create a really important supportive environment, and you not only allow reporting, but you really encourage reporting and support it, it creates a safety culture that creates a better sense of well-being. And I think if you were to talk to my colleagues who were at IHI this week, that would be such a primary connection that they would make, because when we do both of these things well together, we succeed so much in both of them. I'm just looking, I think I didn't look at my notes, which looked a little crazy, but I think I covered all of this. I don't have to tell this audience about all the things that we are doing and can be done to reduce the burden, the moral injury and the burden, but so much of it is around the quality of care and the safety of our patients, and it's so interactive with that. So I'll cede my time to the chair and see if we have any questions. Thank you.
Thank you. And of course, our time is fleeting, but I just wanted, so again, thank you, Terry, because I think you've reinforced a couple things. One is the link between quality and safety and health workforce well-being, but also I think it's important for us to reflect on the 25-year history of how the culture of safety and the movement for quality and safety has matured, and how it has had such a phenomenal impact. Again, recognizing there's differences in terms of how well it's implemented, what the commitment is and philosophy of leaders. I mean, very similar parallels, but I think we still have things to learn as we think about what is the next stage for this movement. How do we move from this plateau that we find ourselves on at the moment because of some of the other uncertainties and pressures, and what do we need to do going forward? I don't know how many of you had an opportunity to review the responses that were sent online in advance of the meeting, but there were several areas that I did not find surprising. The question was, what are the challenges and solutions? And just to kind of give you a very high-level recap, 51 responses related to staffing shortages, 50 responses related to funding cuts and higher demands in terms of workload. We had 47 responses saying there was a lack of buy-in, awareness of the issues, and messaging or framing. 43 responses talked specifically about ongoing burnout, anxiety, and low morale. And then a sprinkling of answers related to health inequities in care and the impact on underserved communities. And then also only 3 responses said AI, which is interesting. And so I think we only have time for like 1 or 2 questions. And so I will turn to our audience here. I see we have one person going to the mic.
Thank y'all for your presentations. You've made me think about something in my own health system. Maybe we collaboratively need to think about what's next. When you said the police officers were kept out of the grants, because that would be too big, it resonated in my head having some midnight sessions, actually, when I led the Safety Workforce at Vanderbilt strategic plan, talking to the police officers about picking up an undergrad from the campus, overdosed, to the ED, they drop them off, they get their care, but that officer immediately goes to the next thing and never debriefed, never understood what happened. Think about our ORs and our EDs when there's a trauma and the patient comes in gunshot wounds, bleeding to death. The entire healthcare workforce goes in, manages the patients. But the environmental services people who clean that room and have to come back in and see the blood and imagine the story, I think what's next is thinking about the system well-being, including the parts of our workforce that are part of the health workforce, even though they're not direct caregivers. And so if we're really going to transform our systems, we've really got to think about the people who deliver the food and see people dying every day. Do they get in on the huddles we talk about when we're all morally distressed about the situation? The officers who bring in our patients, the environmental services who clean up after horrible accidents and horrible events that happen. So you've really triggered here at the last moment of the last session of the last day, a real thought about, gosh, are we really thinking about our system? Because our system is more than the physicians. It's more than the people who do the direct care. It's truly the entire system. And do we include everybody when we're thinking about these? So thank you.
Great point, thanks. Go ahead, Anna.
Thanks. Anna Lager-Dopp. I work for the American Society of Health System Pharmacists. We were one of the 34 grantees that really benefited from the learning community, from the Workplace Change Collaborative. And I've been thinking about this question all day, but it really connects to the work that you did. When we disseminated the conceptual model with occupational burnout and moral injury, you could tell that our members felt heard. And it gave them granularity to what they had been feeling versus this generalization of feelings of occupational burnout. So we've been empowered with evidence over the last several years and these new terms. And then we're now in a phase where we have to think about our audience twice before we say things like evidence-based. And our organization has prioritized the reauthorization and the funding of the Dr. Lorna Breen Healthcare Protection Act. But we're told before we go into offices not to use the term moral injury and not to talk about COVID-19. So I'm just wondering, how do we talk about like cynicism within our healthcare workforce, but there's also cynicism with decision makers and policymakers. So how are we going to make sure that we resonate with them so we get the support that we need?
You want to take that one?
Yeah, I didn't know that. That's fascinating. Is that both sides of the aisle, that moral injury is now a no-no? It's not an executive order, it's just sort of strategic. Yeah, well, I mean, I think, I don't know, others may have other interpretations, that moral injury conjures up the sort of slogan of profits over people, which is not necessarily one that's strategic when you're trying to bring together people from both sides of the aisle. I mean, it's more confrontational for sure, and it speaks to sort of the elephant in the room, to be honest. And so I think that's great to not mention moral injury if it's best not to mention moral injury. I think one of the lessons of this sort of these 3 years with HRSA was, if you go back and look at the RFP, I don't think anybody today would want to do what the RFP says, and even HRSA. And so, we have to learn by doing. And so as long as we can get the resources to do it, I think we figure it out. I mean, the health workforce is not silent about this. They're screaming it in our faces. And as you said, that they were, aching to have somebody describe this additional phenomenon. And so it just will happen. Yeah, but it is kind of unfortunate that it's become a no-no. I didn't know that.
Thanks. Okay, one last question or comment?
Yeah, I have a question. This was a great session. We've talked a lot today about making change for the future. One thing we didn't discuss was really the well-being of those that are in the room advocating for well-being for others, right? Because if we look at the DEI efforts, the chief diversity officers eventually burnt out because of all the other pressures and the moral distress of not making a difference. And so one question I had is because I know Dr. Zhao this morning had said, have a low bar for entry and keep the tent open. And so my question is surrounding awards and recognitions that different organizations, some are doing well, some are starting in the early phases. But I worry about the burnout of those in this room and beyond who are trying to advocate well-being at the local level and then need to do different awards with different things because people don't feel like they're being heard, the different constituents within their system. And so if we're talking about systems, like the comment was about environmental service and everything, how do we get a true, like getting all of us together to advance something that's truly for the system so we don't burn out, chasing after burnout recognition awards? So that would be my question.
You're suggesting awards for people who work on
Not
well-being
for us
issues?
people, our systems, right? So
Oh, for
like
the
there's
systems.
different
I see.
organizations that do
Gotcha.
it. So how do we do it so that
Yeah.
we're all working together for there might be different criteria, but at least it's not so different, so diverse, and that we can make sure that systems are actually thinking about the team, and the team is the environmental service, and it is the EMS person who drops off, and not just singular of one or two or three professions.
Kind of like the opposite of what the Lown Institute does, which is the prizes for the worst. Have
Yes.
the prizes, yeah.
Yeah.
Sounds like maybe an IHI project.
The idea of recognition and keeping momentum going, and I love the quote of the director. I wasn't here this morning, but keep the tent open, bring young passion in to help those of us who might occasionally get tired, I think are good ideas.
Thank you. I think we'll finish. That brings us full circle. We're going to turn things over to Victor to bring some closing comments. So I think bringing together again the fact that we continue to learn. That's really one of the major areas of focus for this group, and recognize that there's still a long ways to go. Victor.